we hope will be many rare disease notebook webinars. A few things perhaps just to note from me at the beginning that are more housekeeping-y before I move on to introduce the excellent speakers we've got today. Just to let you know, you may have seen pop up on your screen that we are going to record today. That's so that we can share it on the website for others who are unable to join us in person at the moment. So I hope that is all okay with everybody. There are feedback questionnaires that you will be invited to fill in for us to help guide us through these sessions, and also some sort of certificates of attendance attached to those. Please do ask questions. Please feel free to pop those in the chat as we go along if you would like to, and I can then help to ask our speakers towards the end of the session. So please pop them in as we go along. Just to say that I think that's probably all to say for now. We'll do a little bit of summing up at the end with sort of extra points, but welcome. Thank you so much. Thank you for joining us. Thank you to Elijah and Claire who are going to speak to us today. The topic of today's session is around the NHS coronial sudden cardiac death pathway. We know that a number of young people who die suddenly will have an underlying inherited cardiac condition, and there are challenges joining up our NHS and coronial services and systems. And we want to ensure that DNA is stored, genetic testing is performed, and family screening is performed where relevant. And so this fantastic initiative, which has been a collaboration between the NHS and the BHF, has looked to address that. I'm sure we're going to hear much more about how we've worked through a pilot phase and now we're entering business as usual for the pathway. And I will hand over to start with to Professor Elijah Bear, who is a cardiologist based at St George's and who has been the driving force behind the sort of inception and then the continued success of this pathway. So thank you for joining us, Elijah. I will hand over to you.
Thanks very much, Rachel. So I'm just going to share my screen, and you'll let me know if you can see everything clearly.
We can, thank you. That's great.
Great. Okay. So yeah, I'll be talking about the sudden unexpected death pilot. The BHF NHS England coronial sudden unexpected death pilot, background to why we do it, and then the results, some of the results that we have from the initial pilot phase. And I think Claire will be talking about how we're delivering it up otherwise in the national rollout. So just a bit of reference for some of the background I'll show you as to why we're actually having a sudden death pathway, and so this comes from these are documents that support what I show you later on, clinical consensus statements such as a 2013 document from HRS, ERAPE HRS, APHRS HRS 2020 consensus statement, the consensus statement on the state of the art of genetic testing with a particular reference to post-mortem genetic testing, and then the 2022 ESC guidelines. These particularly enforce the importance of genetic testing in cardiac pathways. But these all build towards, in a consistent way, what we're delivering here in terms of a pathway for unexpected sudden deaths and for families following an unexpected sudden death. In terms of sudden death in the population, we know that there are around 50 to 100,000 per annum in the UK, although that wide range of numbers indicates that we just don't really know how many are truly sudden deaths and how many may actually be cardiac, because the way we code, unfortunately, is not adequate or up to the task. But nonetheless, when we do more specific focus surveys, particularly in this general population coronial autopsy survey of the 1 to 64 age group, the majority of cases, as you'd expect, are due to ischemic heart disease, with a large proportion being other causes that may include cardiomyopathy, but then a subset that are unexplained, which I'll show more about in a moment. If we then look at a slightly younger age, a younger age group, the 1 to 35-year-old age group, then the numbers do drop significantly. We have an annual incidence estimated up to about 3 per 100,000 per annum. And these are probably the most robust data from Denmark and Ireland. So I think that's probably realistic for a Western European population. But of course, geography and population type will always make differences as well in terms of our estimates. So for example, amongst athletes in Veneto, there's a double the risk or incidence at least of sudden death amongst sports participating individuals and athletes compared to the general incidence, while in the US military is as high as 13 per 100,000, reflecting the age group, the sex, and also some ethnic differentiators as well, ancestry-related differentiators as well that may increase risk. If we look a little bit further down into the younger age group, then the incidence rate gets lower again. Here around 1 to 1.5 per 100,000 person years, or 1 per 100,000 per year, with a distribution that gets even lower as you get into the younger age groups, with peaks at just after 1 year old, and then rising up as one hits the adolescent age groups and the young adult age groups. So there's this J-shaped curve over there. So thankfully, the incidence of deaths in the very youngest is significantly low, but it's certainly not vanishing, unfortunately. In terms of definitions that we use, so the recommendations these days are to use the term either sudden unexplained death syndrome or sudden unexpected death to term as yet unexplained and unexpected sudden death occurring in an individual older than 1 year of age. So that's SUDS or SUD. And the first step for investigating these should always be autopsy, but while we thankfully have access to autopsy through our coronial services as a legal standard in this country, it is not the case globally for certain. I think we are in a privileged position to have access to this. And coroners or medical examiners would therefore be recommended to undertake an autopsy in the setting of an out-of-hospital unexpected sudden death, with retention of tissue suitable for DNA extraction if there's a suspected genetic cause, and if there's a possible expert cardiac pathology. And the reason for this is because we make diagnoses that are potentially genetic, such as hypertrophic cardiomyopathy with pathognomonic disarray and fibrosis present on the histopathology here, arrhythmogenic right ventricular cardiomyopathy, ARVC, showing right-sided dilatation of the heart, as you'll see on this side, with fibroadipose replacement of the wall from epicardial, subepicardial towards endocardial, being again pathognomonic. But here, remember, it's fibrous tissue and adipose tissue together, not just adipose tissue. And of course, dilated cardiomyopathy, where we may have left ventricular dilatation or biventricular dilatation with thin cardiac walls, enlargement of cardiac chambers, and histopathologically evidence of fibrosis, the substrate for arrhythmia. And if we look at these potential causes, and this is an Irish survey of the 1 to 35 age group, we will see that a large proportion of the structurally identified causes are cardiomyopathies. There's also aortic dissection in there, premature coronary artery disease, all that can have genetic bases, and then the unexplained cases, which here is termed SADS, and I'll explain to you what SADS means, sudden arrhythmic death syndrome. And if we look at data arising from Professor Shepherd, Mary Shepherd's database at St George, the Cardiac Risk in the Young Centre for Cardiac Pathology, based here at City St George's. You'll see their experience of over 7,000 referred cases for investigation of causation. SADS is the largest group, followed by cardiomyopathy, and then you'll see a whole range of other potential structural causes. So what is the SADS? Well, it's when there's been a normal heart morphologically, and that means that there's no evidence of structural heart disease, and toxicology doesn't indicate a cause either. So it's an unexplained entity, and it is the most common entity overall in most series of young sudden cardiac death. And therefore, that's our description of SADS. The alternative descriptor or term is autopsy negative sudden unexpected death. Now, you may also be wondering why I mentioned expert cardiac pathology as being important in these cases of sudden death and having access to it. Well, that's partly reflected from this one paper that, again, produced from Mary Shepherd's lab at City St George's, where they examined 200 consecutive sudden death cases, of which around 80% had a provisional diagnosis from the referring pathologist, but only 60% of these actually matched the expert opinion provided at the CRI Centre, and they tended to overdiagnose cardiomyopathy, in particular ARBC, and underdiagnose the normal heart, and that was because of over-applying evidence of fatty infiltration as evidence of ARBC, because there wasn't any accompanying fibrosis. Fat in the heart is normal, particularly on the epicardial surface, and particularly as we become more obese. So this is a table just highlighting that the normal heart diagnoses increased significantly from 57 to 80 in this cohort, and the ARBC diagnoses dropped significantly from 21 to 5. Now, in terms of understanding sudden unexpected deaths, we have two different approaches towards evaluating families, whether we have autopsy available or not, or whether we have genetics available or not. And I'm going to go into the detail of this now. One is evaluating the family in order to diagnose the cause of death and identify others at risk, but also considering post-mortem gene testing or molecular autopsy, which again can diagnose the cause of death and identify others at risk. So if we've had a SUD or SUDS death, and we've undertaken this pathway, we may actually have a cause that could be genetic, such as cardiomyopathy, which would mean appropriate evaluation in an ICC clinic, but also initiating post-mortem gene testing targeted to the phenotype. And by post-mortem genomic testing, I'm referring to the R138 panel or disease-specific panels, where we're interrogating for rare genetic variants, pathogenic or likely pathogenic, that have a high effect size and are very rare or novel in the general population, but may be classed because of their disease associations and other important factors such as allele-specific risk and disease mechanisms, as well as in silico tools. We can class them as pathogenic or likely pathogenic. And if we look at cases of cardiomyopathy that have been associated with sudden death, we can identify the genetic and molecular cause in at least a third of these cases, pathogenic and likely pathogenic variants in about 32% here, with variants of uncertain significance also being detected that may therefore be helpful in assessing family members if we can get our segregation studies working in large enough families. But here we've already got in a third a predictive tool that can be used in families. So if you've got structural heart disease already, molecular autopsy can be very helpful in indicating family members who can be tested or excluded from clinical evaluation. If, however, there isn't any evidence of structural heart disease, then there can be a toxicological assessment undertaken. And again, if that's negative, then we describe that as SADS. And again, we would like to ensure that expert cardiac pathology plays a role here. So the next consideration would be, should we do post-mortem genetic testing here? And we can do a focused arrhythmia molecular autopsy, or consider a broader molecular autopsy. And indeed, that's being increasingly upgraded as being useful, even when the autopsy has excluded evidence of structural heart disease. We may still find cardiomyopathy variants as that are pathogenic or likely pathogenic, and therefore likely to be causative. So we've explored this in research amongst many other studies, but this was the largest study at the time of around 300 cases from international SADS cohort, predominantly from the UK, but also from New Zealand, Denmark, and the Netherlands. And there we studied a 77 gene panel linked to cardiomyopathy and primary electrical disease, and yielded here in SADS cases a 13% diagnostic and immediately actionable yield of pathogenic and likely pathogenic variants, with, as you'll see, a VUS yield that's 42%. So very high VUS yield, but that can still potentially harbor variants that may be useful in the family subsequently if there are enough family members to be assessed. In terms of molecular diagnoses made, the major one found was ryanodine receptor-associated pathogenic variants, which most likely signified CPVT. CRDS hadn't been described at the time the study was undertaken. But also then long QT syndrome and Brugada and cardiomyopathy being diagnosed. Just note that the CPVT cases or RYR2 carrier cases were more likely to be male, likely to be younger, and more exertional, so therefore more characteristic of CPVT, and really potentially very useful way of diagnosing the etiology. Unfortunately, it's sad to say that around 5 of the cases here saw neurologists before they died for apparently exertional seizures. So always important to ensure that we all understand the basis. So the other way of assessing the etiology, molecular etiology of these sudden death cases, is also do trio studies, and this is trio exome sequencing, and we do potentially have access to trio whole genome sequencing in the NHS. And in this case, there were 12 variants detected, of which the majority were VUSs. But by employing a trio approach and triangulating between parents and the deceased individual, and identifying that these were de novo variants in the decedent, one can increase the yield by 50% just from this one study. Now, if we've taken this approach, we also need to go on and assess the family, and do that in the context of the family history and the personal history of the individual, and the circumstance of death that may therefore indicate the likelihood of underlying disorder. But just remember that in some cases, an autopsy may not have been undertaken, often in this country because the death has occurred elsewhere, or it may have been an old case. But when no autopsy has been undertaken, then the suspicions of genetic disease should be heightened by the age of the death, and also as a family history of sudden death or even cardiac genetic disorders. If we go on to look at family evaluation, that always needs to be focused on the immediate relatives, obligate carriers and symptomatic relatives being the ones we focus on, and then undertaking a range of clinical tests that should be part of our basic evaluation, with additional tests to be considered as required. So an arresting ECG may diagnose clear long QT syndrome, clear Brugada syndrome, and the exercise test in somebody who has a normal ECG at rest may diagnose evidence of CPVT, either very overtly, as up here, bidirectional VT or polymorphic VT, or as below, where there is evidence just of asymptomatic couplet activity and triplets of a bidirectional character with exercise. If there's a high index of suspicion of Brugada, one can undertake a sodium channel blocker test, or one can consider a more systematic approach of offering sodium channel blocker testing. This is a matter of personal inclination, I think, at this stage. We don't really know for certain which is going to be the best approach to take, but patients need to be counseled appropriately. And one can also consider epinephrine challenge, although we don't use that at St George's at all. This is an example of a sodium channel blocker challenge test showing a clear type 1 Brugada ECG pattern in the individual undergoing testing, one of the family members. And if you do take that systematic approach, then you can identify quite a high burden of Brugada syndrome. So that's the most common clinical diagnosis that we find. And if we combine family evaluation with molecular autopsy, we increase the yield significantly, so that we can have an increased yield of 50% diagnostic yield. And if we look at our most recent data of over 700 cases of SADS and families with SADS, some which had family evaluation, some which had molecular, some of whom had molecular diagnoses only, and the combination of the two in others, we see an overall steady yield of Brugada syndrome amongst families with age, a steady yield of long QT syndrome, particularly higher in the younger age groups, and CPVT at a much higher prevalence in the younger age groups and much less in the older age groups. Females had a much greater diagnostic yield than males, and notably also with long QT syndrome. And just to indicate here that family evaluation is important across the age groups, and molecular autopsy more helpful in the younger age group, maybe reflecting our eligibility criteria for the R138 panel currently. And the long QT syndrome yield, again, family evaluation drives a lot of it, but as does molecular autopsy. But molecular autopsy particularly drives the CPVT yield. If the autopsy is ambiguous, then one still treats the equivocal autopsy as if it's SADS, because even if you have a floppy mitral valve, some fatty infiltration of the right-sided heart, or just some unexpected hypertrophy or fibrosis without signs of actual cardiomyopathy, we still find among these ambiguous non-specific autopsy families strong evidence of channelopathy, Brugada syndrome in particular, but even long QT and CPVT. So if a diagnosis is made, the families can be managed in the ICC clinics and followed up appropriately. If a diagnosis isn't made, then adults are discharged. If the gene test is negative from a post-mortem gene test, then this is the clinical pathway, but we can always use our predictive testing to exclude or include people or individuals from families where there is a positive molecular autopsy. So we've applied this research and the guidelines arising from it to improving the pathway for sudden unexpected death in the UK. We think there are around 750 of these deaths in the younger age group per annum, predominantly likely to be due to inherited cardiac conditions, either unexplained or structural. And the aim from the pathway improvement was to aid earlier identification, assess the surviving family members, institute early treatment, and reduce the risk of premature death. So the transformation project that was undertaken involved the chief coroner and the Coronial office and the Coronial teams of a number of districts that I'll show you in a moment, the Royal College of Pathologists, NHS England, Genomics England, the British Heart Foundation, and Cardiac Risk in the Young, a powerful coalition of stakeholders to develop and test the pathway between the coroners and the NHS to improve systematic access to genomics and clinical testing, and address the needs of families appropriately. And this required working with the coronial side, coroners, their officers and pathologists, cardiologists, geneticists, and cardiologists who deal with children as well as with adults, and cardiac genetic nursing team and counsellor team, and genetic scientists and GLHs. And we undertook this in 7 pilot sites across England. And these are the pilot sites according to GMSAs. So you'll see, for example, North and South London there, and the Southeast GMSA. South London was the representative region, but we included, but there were other areas, including Manchester, including Sheffield, Leicester, Birmingham, and Bristol. And we established a consistent pathology practice, including expert pathology, with access to the CRI Centre at St George's or to a local expert pathologist in 3 out of the 7 centres. Routine tissue retention for DNA extraction, established a pathway between coroners and the NHS services for families for genetic testing and clinical evaluation, and a mechanism for standardized post-mortem genetic testing using R138 and R441, particularly for unexplained sudden deaths and disease-specific panels for structural diseases. And the aim was to develop and disseminate this best practice nationally for adoption, as you'll see, and engagement and input from patient support groups, and to develop the evidence base for a proposed national rollout. The inclusion criteria for the pilot, which is slightly different from the national rollout, as you'll see as well, is that we had sudden unexpected death cases reported to the coroner, which included as well cardiac arrests where resuscitation had failed with no recovery, but the case was still referred to the coroner. Age 1 to 60, we allowed exceptions for those above 60 when that was agreed by the teams because of associated history, for example, a family history of sudden death or a family history of inherited cardiac disease. And either with a suspected cardiac genetic cause at autopsy or unexplained despite full coronial and expert cardiac autopsy and pathological testing. So that means SADS. So the process that went through on the pilot, and you're going to get more detail on how to set this up from Claire in her presentation. So the coroner's case is firstly opened. The post-mortem examination is undertaken at request of the coroner's officer of the coroner's pathologist. If a genetic cardiac condition is identified or suspected, this is reported by the pathologist, and this is all part of new practice. But instead, they flag this up to the coroner's officer and indicate the need to retain tissue and retain tissue at the time. Now, this is all under coronial rules, which allows the pathologist to take tissue, but then we do need to have some consent in order to retain it longer term after the coronial investigation is finished. There's a 3-month period given by the HTA to allow this process to occur. But ideally, this all occurs at the same time, instigated by the coroner's officer, using specific consent forms that have been designed to support matters. And this is confirmed to the pathologist, who arranges storage of the tissue locally, as they would normally do for blocks of tissue and slides. But then the tissue, as Claire will describe to you, would need to find its way to the genomics laboratory hub for DNA extraction and genetic testing if consent is given by the family. And this is where the ICC coordinator is critical. The coroner's officer indicates to the family and signposts the family to the ICC coordinator, who is usually a cardiac nurse, specialist nurse trained in ICCs, to initiate the process of the family entering clinical services. So all these processes have been supported by the British Heart Foundation and the Cardiac Risk in the Young, developing appropriate material for coroner's officers to use for families, to give them the right information and to ensure that coroner's officers have a streamlined approach. And indeed, our evaluation has suggested that coroner's officers find this actually improves the efficiency of working compared to how they used to work, which was a much more ad hoc and difficult approach. In terms of the pilot, there was a variable recruitment across the different sites depending on when the coordinator was appointed and for how long the recruitment went on for, but it was roughly just under a year across all the sites, the 7 different sites, and 108 cases were included. And this is interim, but not final data. But you'll see SADS, again, as the major etiology, but we do have evidence, again, of cardiomyopathies and aortic dissection, as well as unexplained entities such as unexplained fibrosis and unexplained hypertrophy. And these all potentially could harbor genetic causes. There were just under 500 families identified and signposted. The majority did enter the ICC services. So that's the 252 out of the 489 over here. And then a significant proportion were identified as either having phenotype, having genotype according to genetic postmortem gene testing, having both, or being completely negative. And there were also those who were phenotype negative with no genetic testing available. And there were 104 cases where we're still waiting for the final data to complete our analyses. So early evidence here is that we are providing a really clear diagnostic yield, and there will be individuals who can be reassured and discharged very quickly from the processes. In terms of the process over the periods of recruitment across the various sites, this just indicates to you the total deceased in blue along the bottom, the orange in terms of the total bereaved family members that we identified, and then the grey in the middle, so those who actually joined the ICC service. And there was an opportunity for relatives to return. They were given information about how to return to the service if they didn't wish to engage to begin with. So conclusion, we've shown previously from research that we need to evaluate sudden death cases with expert pathology, with whole heart and DNA retention to facilitate that and to facilitate molecular autopsy. Ambiguous pathology should be treated as SADS until proven otherwise. And the diagnostic yields are greater in females with long QT syndrome in childhood and adulthood, CPVT in childhood, and Brugada syndrome across all ages. In terms of evaluation of SADS families, we focus on immediate family members. We don't want to bring in extended family members unless it's absolutely necessary if they're syncopal patients or obligate carriers in a pedigree, but it is effective across all age groups of unexpected sudden deaths. In terms of molecular autopsy, clearly it plays a role in cardiomyopathy and structural disease, but also in SADS, and that the greatest yield being in younger SADS groups, and hence R138s are focused on the below 40-year-old age group. There's the importance of sporadic CPV detection with CPVT detection with molecular autopsy, and also the potential of identifying cardiomyopathy even in autopsy negative cases. Trios are a way forward for those that are more challenging, and particularly for the younger cases. So the national pathway is now rolling out, and I think Claire is going to show you how that learning that we've established from the pilot studies is now being applied to extending throughout our regions and extending the North and South London regions out to the rest of the Southeast and the North Thames GMSAs. Thank you very much.
Thank you, Elijah. That was a great talk, very comprehensive. I will very shortly hand over to Claire. I think there was a question that appeared in the chat, and then I think you answered it around DNA storage and how consent is then taken by the Coronial team. Quick question from me, because I know it's something that we're talking about around the family members and how to engage them in the screening process. We obviously saw some uptake, but a number of family members who haven't yet engaged. What do you think the barriers are to that? And is there anything that we can do to try and help that process?
So quickly, just about the consent. So I think in some areas, depending on the local arrangements, DNA will be extracted straight away under coronial rules because it's allowable at that stage. But if this tissue is stored, then it may be up to the ICC coordinator to gain consent for DNA extraction. But the coronial officer, in all cases, will have provided a form where they have indicated the family's wish for retention, either signed by the family or signed by them on behalf of the family, which is acceptable to the HTA. That's the current practice. And that's been working for quite a while now. In terms of the barriers for families engaging, well, I mean, there is just the awful bereavement trauma that some may be suffering that just mean they cannot even think about engaging in a clinical process early on, which is why I think it's important that we do offer them the opportunity to come back, and some do, and do engage at a later stage. You may get parts of a family engaging and other parts not. So, for example, we know from our own experience that there are less male adults attend than female adults. And that's partly because I think men just tend not to seek medical help as much as females. So we do have to acknowledge that and take a particular opportunity to try and ensure that male relatives understand the implications for them as well and for their family members, and that they and their family may benefit from it as well. And then there are cultural issues. Say, for example, Jewish and Muslim families may wish to have the body dealt with as quickly as possible in line with religious law. That may preclude some of the pathway existing on being taken forward in what we would term the correct approach, and therefore I think we have to make adjustments there to deal with these cultural differences and barriers to uptake of potentially important healthcare opportunities for these families, and leave the door open. And I think therefore means a lot of our documentation also needs to be tailored in terms of any language barriers that may exist as well for families to improve understanding. So there's a lot we can do. There's a lot the BHF have been doing and CRI have been doing to improve this, and we can keep on building on that work through the national rollout.
Thank you. Thanks, Elijah. One other quick question before we move on to Claire, asking whether you have any thoughts on the age-related differences in arrhythmia syndrome presentations, presumably. And I think that's asking whether it was based upon data from the molecular autopsies.
Yeah, I mean, yes, it is. So, and also some from our clinical evaluation as well. The majority of the of our unexpected sudden deaths tend to be young males who die at rest or asleep, young male adults, and that's quite consistent with the presentation with Brugada syndrome, or maybe some of the allied conditions that we're starting to understand a bit better, J-wave syndromes and associated etiology. So even idiopathic VF that we would see as a cardiac arrest that's unexplained. Otherwise, when we do clinical evaluation, these are most often young adult males as well. So there's clearly an unexplained etiology there that's difficult to interrogate and usually occurs at sleep or at rest, and we can make that phenotypic association there. But with the molecular autopsy studies, we clearly see evidence of RYR2 CPVT-like disease and younger male exertional death. And we see long QT syndrome particularly associated with female adults, young adults. And that's, again, associates with the clinical phenotypes that we see as well. That's the highest risk age group amongst young adults, but there's also there in the child age group. It's just, we think RYR2 disease is probably a bit more common as a cause of sudden death in that age group. Understanding why Brugada syndrome is important in the young age group as well, I think is a challenge. We don't necessarily recognize that clinically, but some of the experience from the French, for example, indicate that Brugada syndrome in children is actually underestimated in terms of its risk for children, particularly if they've got sodium channel disease. And just remember that younger children are the lowest proportion, thankfully, of these sudden deaths. But as an absolute proportion, probably, or as a proportion, probably Brugada still is very important in that group. It's just that we got more monogenic disorders that we can diagnose in the child age group as well.
Thank you. That's really helpful. I'm going to now hand over to Claire, if I may. So to welcome Claire Kirkby to the webinar. Claire is ICC coordinator in North Thames, and Claire was one of the original ICC coordinators. So she has experience of pathway setup throughout the pilot and beyond. So she's kindly agreed to share some of her learning and that experience with us today. So welcome, Claire, and thank you for joining us.
Thank you, and thank you for inviting me to talk today. So I cover the North Thames region, and I'm one of the coordinators. So we're given the title coordinator because we are a mixed group of both genetic counsellors and CNSs by background. So I want to guide you through the pathway, talk about the inclusion criteria, and discuss how to set up the coronial area, particularly for the new coordinators coming on board, and add in any tips or tricks along the way for setting the pathway up. In the pathway, there are lots of documents that are given to the coordinators for the pathway. The actual pathway itself is detailed in the 4th document. For the coordinators, please go through this in detail, all the documents. But for everyone else, I've summarised things in my next slides. So I'll be talking about the sudden cardiac death aspect to the pathway, but it is worth bearing in mind that we're also going to be opening up to cardiac arrest survivors as well. But for today, I'm just talking about those who have died and then going through the coronial part of the pathway. So when there has been a sudden and unexplained death, so where the death certificate or MCCD can't be issued by the medical examiner, they're referred to the coroner, and then the coronial case is opened. A post-mortem is usually then performed by the pathologist. If the pathologist suspects a likely or definite inherited cardiac condition, or ICC, we're asking them to do 3 things. Firstly, to save the spleen. Secondly, to consider cardiac pathology. And then thirdly, to inform the coroner's officer that this is a likely inherited cardiac condition. With the pathway, there are a number of options you can utilise for your coronial area, and a lot will depend on the facilities available in the mortuary and the workload of different staff groups. So ideally, we're asking that the pathologist saves the spleen under the coronial jurisdiction of establishing the cause of death. Because you can only take tissue during the post-mortem, in some cases, especially with the SADs, the pathologists have to preemptively take the spleen. We're asking for a 0.5 centimetre cubed piece of spleen. And this is because we are most likely to get a good amount of good quality DNA from that. For that tissue, we either need it to be stored in a -70 centigrade degrees centigrade freezer, or in a fridge with a solution called RNA later. It cannot be put into formalin because this gets rid of the DNA. For RNA later, most coordinators will then provide this to the mortuaries and obtain it through their GMS, their genetic medicine service. With this option, it stays in the mortuary until the end of the coronial case. And then if the final cause of death shows an ICC, then the coroner's officer will talk to the family about retaining the tissue after the coronial case has closed. However, some coronial areas are allowing the coordinator to be involved quite soon after the post-mortem. So it could be that it's the coordinator involved while the coronial investigations are ongoing. And then they will have had the opportunity to talk and explain to the family about how helpful it is and what the benefits are to storing that tissue for a genetic test at a later stage. What I would say is, though, if you can't, as a coordinator, if you can't speak to the family while the coronial case is ongoing, is that if they have declined, if the family have declined to store that tissue at the end of the coronial case, that you're allowed to then very quickly get in touch with the family, and there's that small window of opportunity where you then can talk to the family and explain that at the end, very end of the coronial case. Another option at the point of the post-mortem that some coronial areas are utilising is that the tissue is then sent for DNA extraction and storage. So very soon after the post-mortem, it's then sent to the genetic laboratory hub. The mortuaries tend to prefer this option. However, it's worth bearing in mind that more samples will be taken and DNA extracted than will actually then need testing, because the final cause of death then turns out to be something like a drugs-related death or some other cause. And then just to say with this, depending on who's involved at this stage, it will either be the coroner's officer or the coordinator who talks to the family about that consent for DNA extraction and storage. The second thing we're asking the pathologist to do is consider performing a cardiac post-mortem. Now, that might be referring out to a specialist centre like the CRI Centre with Professor Mary Shepherd at St George's, or to another cardiac pathologist more local to you. Or it might mean performing it locally on site, depending on what has been seen on that initial post-mortem. For both options, the coroner's officer will need to consent to retain the tissue at the end of the coronial case, as is previously mentioned. The third thing that we're asking the pathologist to do is highlight the patient to the coroner's officer. At this point, the senior coroner may be happy for you to be for the coordinator to be informed of the family in the case. However, they may want to wait until all the results are back. For me, I'm normally waiting until the end of the coronial case. So what I'm starting to do is ask the coroner's officer to ask the family about red flag symptoms. So particularly things like exertional syncope in the deceased or any relatives. Something that might mean that you really want to expedite those clinical referrals through to their ICC centre for screening, to make sure that they are safe. This is the pathway as a whole. The only other thing I would mention is that GPs can refer through into your service. If some of these cases have been referred through to a general cardiologist or to a neurologist, they may want to refer through if they've picked something like this up historically in the family history of a patient that they're seeing. It's also, with those GP referrals, it's also a good safety net to make sure that you're capturing families, even if something was missed in the coronial part of the pathway. The coordinator then, once they're involved, can then support the family, signpost to bereavement services, provide information about the heart condition that's been found, talk through about clinical screening for those relatives, those first degree relatives, and arrange the molecular autopsy in their loved one who died. Moving on to the inclusion criteria. So again, for the coordinators, this is detailed in document 6 of the pathway, but I've summarised it in my next slide. So anyone who has died suddenly at any age over the year of 1 year of age will be included. For the structural heart conditions, we're looking for those with a cardiomyopathy, aortopathy, and or mitral valve prolapse. For the cardiomyopathy, so it's those with hypertrophic cardiomyopathy, dilated cardiomyopathy with no other cause that can be explained, and arrhythmogenic cardiomyopathy, and that's left, right, or biventricular involvement. We're also looking for those with unexplained hypertrophy, unexplained fibrosis, and obesity cardiomyopathy. Those with a thoracic aortic aneurysm with a dissectional rupture, and then also those with severe mitral valve prolapse with myxomatous degenerative valvular disease. In the structurally normal heart on post-mortem, we're looking for those once all the other tests are back, including toxicology, no other cause of death was found, and then it's put down to SADS. So those we suspect are the inherited arrhythmias. On the post-mortem, it might also be labelled as unascertained or unknown. And these are the inclusion criteria for relatives to be recommended clinical screening, so referred through to the coordinator. But as some of you may know, there are some cut-offs with genetic testing that are slightly narrower than that. For the molecular autopsy, it's 1 to 60 for the cardiomyopathies and 1 to 40 for those with SADS. However, as I'll go through in the next slide, there are exceptions. It's quite a wordy document, so I'm not going to go through it, but essentially if there is a family history of one of these conditions or a prior sudden death in the family, then normally you can widen out that age inclusion. With the thoracic aortic aneurysms, you can go up to 60 years if there's a family history of the condition or syndromic features of a related connective tissue disorder. And then again with the SADS, you can do the 40 to 60-year-old age group if there is a prior family history of sudden death. So really for the coordinators and services setting up this pathway, I want to talk through kind of the process of setup. The probably best piece of information or kind of tip I could give is to get a map and really look at where your GMS region covers and where each of your coronial areas cover. You can look at the Coronary Society website, that gives a map to see who your senior coroner is, their contact details, and where your outliers are, because the boundaries don't always line up. Contact your senior coroner. I normally do this by email and attach a covering letter. I also add the family leaflet that was produced by the BHF and CRY, and then also add in Professor Shepherd's publication into the email. If you don't hear back, that's okay. It's probably just that they're busy or it's been missed in the many emails that they receive. So a couple of weeks later, just email again and just keep nudging them every couple of weeks. I would also add in any and mention any adjacent coronial areas who are signed up to the pathway and what the benefits are to the families. So how many families you have helped. If you have any problem, then go to the BHF team who can also help. Once you've got a meeting set, then you want to engage with the British Heart Foundation, who will also be part of that first meeting. And they create the presentation. I would also add in a few slides. So I tend to start with a case study because you can really show how important the entire pathway is to our families. I'd also add in a map about the coronial area, read up on the population and demographics, just so they know that you understand their area and think about what, from their perspective, might be important to them. I then finish up with like the next steps, so what I would like from that meeting and kind of guide them through what the next steps are. So you want a list of all the mortuaries, the pathologists and the coroner's officers so you can set up meetings with them. And then at the very end of all those meetings, you'll then go back to the senior coroner with any issues or feedback and before you then go live. Then you have the meeting with the pathologist and the British Heart Foundation. At this meeting, again, I'd really find out how many cases they generally see, whether they have a lot of locum pathologists in their area. Are you only capturing those who are substantive within the area, or are there lots of locum pathologists who you're perhaps not getting to meet during this training? With the mortuary managers, this might be held along with the pathologist or as a separate meeting. This meeting, I'd really find out what facilities they have for storing tissue, what they usually do. Do they use the cry service? What other cardiac pathologists do they refer to? And if they do have kind of a freezer or a fridge, do they have RNA later already? And then, as I said, you feedback any issues to the senior coroner, and then you can go live. Just kind of my last slide. Once you set up the area, great. Then just think about what's next. You want to keep working on the other coronial sites that you need to open up. I would thoroughly recommend visiting the coroner's courts, the mortuaries, and meet as many staff as possible. I won't keep going through that. It's there in detail. I'll stop sharing, and then if anyone has any questions.
Thank you, Claire. It's a wonderful talk. You've made what is very complex pathways sound very straightforward, and I know you've done so much work to do so. So thank you. There are a couple of questions in the chat, and between yourself and Elijah, you may like to address these. The first was around tissue storage. So following gene testing, a query around long-term storage of tissue with respect to HTA standards and genetic labs, whether or not they are able to store tissue on a long-term basis. Would either of you be happy to address that?
I would normally say that once it goes to the GLH, it's so we're asking for half a centimetre cubed, so that there's no tissue remaining after the DNA has been extracted. So the GLH just has enough to get the DNA, and then there's no further tissue there. So it's then outside of HTA guidelines, because everything is then as DNA. Elijah might want to say something else.
Yeah, I mean, it is only a small amount, and much of the time it may be exhausted by the DNA extraction. But I do know that we can, it's very DNA rich, so we can have tissue left over. So those cases that come to Mary quite often come with the sample in RNA later, as Professor Shepherd, just because the pathways to local GLHs haven't been set up as yet. And we do run the research program around these samples, and in that case, then we do retain, because we do have an HTA license and we do have the facilities to retain the sample. But if it's gone to the lab, then I think and there's nowhere else for the sample to go, and there's sufficient DNA retained and stored, then it needs to be just disposed of respectfully according to HTA regulations and the wishes of the family. So in some circumstances, the family may wish for any tissue to be used for research, for example, in which case it may be returned. But in general, I think it just needs to be disposed of respectfully.
Thank you. We had a coroner who joined us today, so welcome. And I can see you had some correspondence in the chat, Elijah, around
Yes.
the being able to loop in and link in with your ICC coordinator, and it looks as though you've perhaps been able to answer some queries there. I think probably message from us would be to share that there have been a number of new appointments, haven't there, into the ICC coordinator roles lately. We're pleased that many of those are hopefully on the call today and have joined the call today. And so there has been a bit of a change of staff, but we will be looking to try and disseminate details and help to link up wherever we can. I don't know, and that's through our BHF partners within this, and Amy, who's on the call as well, who's one of our project managers. Is there anything else from any of you to add around that?
So from me, in terms of Nottinghamshire, which is where Lorinda is based, I can't remember which where the geography is going to be covered from there. That's East GMSA, isn't it? For so whether that would come through Cambridge, or whether it would, where the best location would be for that one, if there's a coordinator nearby. Claire, do you know the location? Do you know the geographical location? You're looking at a map, it seems.
There I am. I'm not sure. It might. I think. Yeah. There is a coordinator in Nottingham.
Tracy Welsh has put her hand
where
up on
Amy.
North. Yeah. See if Tracy can tell us.
Tracy, you may be able to answer that. I don't know whether we've muted your mic, and if we have, we will try and unmute it or ask you to perhaps pop something in the chat. I mean, I guess this is something we will obviously be asking the new coordinators to start to reach out to you as well. So any coroners who are on the call, you will hopefully receive those emails that Claire talked about and correspondence from them. But certainly these are bits where perhaps we can take away and think about how to help form those connections throughout as well.
Tracy can talk now. She's got her. She can use her mic.
Please go ahead, Tracy.
Or maybe not.
Possibly not.
Okay. Lorinda, I'm sure somebody's going to come back to you about the coordinator for you to contact, because this is a great opportunity to get the ball rolling.
We will do.
Yeah.
Yeah. I think
Carmela's just put something in the text. Okay.
So that's around our GMSA newsletters, I think.
Yes.
So I sorry, Elijah.
And there's Rachel Knight has just mentioned is a coroner in Wales. And Rachel, this pathway is actually NHS England at the moment. Is for NHS England area at the moment. But we know that the processes are being duplicated in Scotland and in Wales. And so that there is an opportunity for these pathways to operate in Wales. And there are ICC centres in Wales that can provide that service. So I think it's something that we can certainly arrange for sharing.
Thank you. And I think we've had a couple of the coordinators' emails just popped into the chat there as well to hopefully answer for Lorinda. We're just over time, so I'm going to draw to a close. But thank you very, very much, Elijah and Claire, for your wonderful presentations. Really great to hear about the work that's happened already and to, continue to help move this forwards. Thank you all for joining us today as well. We will have another one of these set up for April, which is going to be looking at patients with heart failure, hidden in heart failure. So our next rare disease webinar. But for now, thank you to you all. Thank you to Elijah and Claire, and see you again. Bye-bye.
Thanks, everyone.